Good afternoon, colleagues, and a very warm welcome to our NHS England National AHP Programme webinar today. My name is Claire Ardito. I'm the Head of Allied Health Professions for NHS England, and I'm delighted to be bringing this webinar and expanding horizons, building the future of the AHP educator workforce to you today. This is the fifth webinar in our series for 2025-26, and all of these webinars are focusing on our key priority areas for the AHP workforce, training and education. Our ambition is to share this suite of webinars with the AHP community as a comprehensive resource to support knowledge sharing, implementation and innovation of all of the initiatives that we're sharing with you. Next slide, please. In terms of how we're running the webinar today, we will be sharing the information through the webinar with two speakers that we've got today, and there will be an opportunity to ask questions as we go through the webinar through the Q&A function. We won't be able to take any live questions today, but certainly you can ask questions and we'll aim to try and answer those as we go through. And if we don't, we'll pick them up after the webinar to identify any areas perhaps that we haven't met your needs, and we can share further information in the future if needed. If you're really interested in a question, please do feel free to vote. And also there's an opportunity to turn on captions if needed, and we'll be sharing that information for you. At the end of the webinar, we'll be asking you to complete a survey. There'll be a QR code for you to link into, and also we'll be informing you of future webinars. We hope that you'll join us for those as well. And if you do sign up to give us some feedback, then we'll also be able to share the slides from the webinar today with you. Thank you. Moving on. So the aims of today are to bring to you the Educator Workforce Programme, and included in that programme we'll be giving you a real clear update on what we mean by the educator workforce. Many of you may be very close to this agenda already, or some of you may never have heard very much at all so far. So hopefully you'll go away with plenty of information, giving you the most up-to-date information and updates. And also we will be sharing with you a new approach, a maturity approach to utilisation of the educator workforce strategy. And this will include a clear overview of the rationale, how we've worked collaboratively to get to this point today, to give you more detail about the maturity framework and to think about the implications for both the allied health workforce, both our leaders in our allied health community, but also those of you who are working more broadly across the educator workforce sector. So thank you very much for joining us today. We're delighted that you're here, and I have great pleasure to introduce the wonderful Professor Deborah Harding. She's been leading the AHP contribution to the National Educator Workforce Programme, and many of you will know Deb in her role as subject matter expert for the multi-professional supervision in the Centre for Advancing Practice in NHS England. Thank you, Deb, and I'm going to hand over to you.
Thank you, Claire, and thank you for the opportunity to share some of the detail of the Educator Workforce Programme, and specifically work which we'll be launching quite soon to provide a framework and self-assessment for educator workforce maturity, and particularly today, how that is relevant for colleagues across allied health. There's a lot to cover, but the slides I think are going to be made available to you later so you can digest them more. As you know, share thoughts in the Q&A and we'll do our best to pick them up, but we'll certainly be capturing them and feeding them into the programme too. I'm conscious that it's a challenging environment with lots of scrutiny about the workforce, and that education and educator posts feel really vulnerable in this context. We don't have magic solutions in the Educator Workforce Programme, but we are striving to prompt a change in culture about the educator workforce, making links between educators and high-level metrics which trouble our NHS leaders, things like safety, equality and productivity. And this change will take time, but we are working with colleagues across the NHS and education to create guidance and frameworks which we hope are going to assist that cultural shift. So without further ado, the first thing that people always ask in this programme is, what on earth do we mean when we're talking about the educator workforce? So defining the educator workforce is tricky. It's evolved iteratively over time, resulting in many different job titles across the workforce and professions, and that then makes it really difficult to establish a baseline or be clear about educator workforce capacity. Next slide, please. So as a way forward, what we've done is build on work which will be familiar to many of you as AHPs and was led by one of the AHP Leadership Fellows in London, Ellie Melcoon. From her work looking at AHP educators in London, Ellie proposed categories of educators, which we shared more widely with experts and educators beyond allied health. And we found there was agreement that the approach could provide a consistent mechanism for defining and identifying educator roles, and that could assist NHS organisations to evaluate and plan the educator capacity which is required to ensure the support of learning and development needs for the future and current workforce. For the programme, we've got some inclusions and exclusions, which you can see here on the slide. So in essence, we're talking about roles that are funded by the NHS. We're at the moment focusing on the clinical workforce. And where there are roles that perhaps sit in the exclusions below, then we're talking about the NHS funded portion of those jointly funded posts. At this stage, we're excluding academic education providers, so schools, FE, the universities, public health roles, professional bodies and regulators, and roles in administrative support services and estates. Now, it's important to recognise this point at the bottom of the slide, that those groups, although currently out of scope, are essential to the education provision and capacity of the NHS. So subsequent iterations of this work will seek to expand the scope once this iteration of categories has been implemented. Next slide, please. So the categories move through from overall governance and policy through to education delivery, recognising that not all educators have protected time. Appreciate the text on here is quite small, but what we have identified are examples of what those overarching arm's length body roles are, so deanery roles, heads of school and so on. And then when we move into organisations, the people who are accountable for the educator workforce. So we're looking for one individual in each organisation. We'll say more about that, but somebody who's really either at board level or a partnership role in primary care, who's aware and alert to all of the learning needs across their workforce, and then through to who is actually delivering that in an organisational sense, who's responsible for the delivery of the education itself. And then recognising that very, very many of us have education embedded in a clinical role. So that's not to hide away that educator aspect of, suddenly suggests there's a lot of capacity because it's in a clinical role. It's just to recognise that is often the reality. On the next slide, what we have are, I guess, a best guess at the moment, collaborating here with Claire to identify what sorts of roles we might see in each of those categories with through an AHP lens. So that individual role, again, may well vary greatly across organisations, and in most cases will probably not be an allied health professional. But then at organisational oversight level, we would expect a chief AHP perhaps to be taking that role. We might expect to see in organisational educational leads, practice education and development leads. These might be pan-organisation. Again, they may not be specific to allied health. Project and programme educator examples might include team lead roles, and I know you've got examples in diagnostic radiography around practice educator facilitation. Those education at local and specialty levels, that might be a designated clinical supervisor, for example, in advanced practice supporting MSK, advanced practice development in physiotherapy. And then all of our senior AHPs will have some education role, and at some level, all staff. Of course, all of us are educating patients all the time, so that need to invest in our education pillar is woven through everything we do. Next slide. So what are the implications of those categories, which I know will be familiar to many of you, but what are the implications from an allied health perspective? And what I really want to encourage colleagues to think about in your organisations, in your practice environments, are who are your educators? What job titles do they have? If you're in a leadership position, maybe examine whether there's anything you can do to consolidate those job titles a bit. Make your educators easier to spot in the system, and also make it easier to spot where there might be gaps. What's the educator workforce infrastructure in your organisation? Who leads that? Where do you think it might be most mature in your organisation? And what prompts you to think that? What sort of impact is there where you think there is a mature educator workforce? If you think that's in medicine or nursing, what impact do you see it having? And what could you learn from that? And then how can you use that intelligence to help those with responsibility for the whole educator workforce to understand and to advocate for AHP educators? Particularly, of course, we are concerned in allied health about some of our smaller professional groups and those that are vulnerable. Next slide, please. So I just now want to refresh your memory, hoping that you have some insights already into the educator workforce strategy, but it may well be news to some people. But let's just have a little think through what that strategy is about. So the educator workforce strategy has been around for a couple of years now, and it identified 7 priorities. And as part of the implementation programme, we've identified a further 8th priority, which is about realising the benefits and impacts of educators, and that's been added in. So it's also become very apparent as the programme has evolved that these priorities make kind of different contributions to the overall programme. So over the next few slides, I'll try to explain that. First of all, if we move to the next slide, to supply and retain a safe workforce requires us to have educators and the educator workforce really integrated in all our planning agendas, so wider workforce planning. Next, we have some priorities that are really focused on building the educator workforce that's required. So protecting educator time and resources is one of them. And the next one is about having career frameworks for educators. We have an education framework in allied health now. So that's one of the places we're perhaps a bit ahead of some of our other professional groups across the NHS. And also an aspect of building on our next slide is about those principles for educators, which we're going to tell you a bit more about in today's webinar. Next, we have some priorities which are about sustaining the educator workforce, and that's about how do we support educator development and well-being, and also how are we capturing the innovative models of education, making sure that we're sharing best practice and spreading innovation across the system. In our next slide, we can see that underpinning all of this, we have this golden thread of promoting equality, diversity, and inclusion. And then finally, that marker of success will be how we realise the benefits and the impacts of educators. And what I just want to say there is that as allied health professionals, really have your antennae out for where education-led activity is having an impact on those high-level metrics that keep our NHS leaders awake at night. So how are those things that are education-led and informed having an impact for safety, for quality, for patient outcomes, for recruitment and retention, for length of stay, and so on. It might be a very tenuous link in the beginning, but really have your antennae really firmly focused on trying to find those examples of impact. Next slide, please. So obviously the programme is one of many programmes from NHS England, and what we are striving to do in this programme is not reinvent the wheel, but to identify where there are synergies with other priorities and programmes of work. And some of the most obvious ones will be the quality framework that's been around for a long time that came from HEE, where we have education provision in practice, aspects of the People Promise, the NHS Equality, Diversity and Inclusion Plan, and of course the Safe Learning Environment Charter, which I'm sure many of you are already actively embedding in your practice environments. Of course, what we also need to do, and we're starting to do as a programme, is to highlight the ways in which educators and the Educator Workforce Programme will be vital enablers for the Fit for the Future ambitions. So really considering the role of educators and education in preparing the current and future workforce to navigate and deliver those 3 key shifts about moving from hospital to community, making better use of technology and focusing on prevention. So again, I guess a call to action for colleagues from the allied health world is to think, what sorts of educator and education intervention and capacity do we need to equip our workforce for these shifts? Because we're really asking them to work in more agile and ways in which potentially we've not really thought about or hadn't been thought about when we were initially training this group of professions. So how do we think about stepping up and responding, enabling these shifts? So I think next I'm going to hand to Antonio, who's going to talk through in a little bit more detail where we've been going with the work on priority 5, which is about standards and principles. Thank you, Antonio.
Thanks very much. I'm Antonio De Gregorio. I'm an Education Reform Programme Manager working in NHS England, and I predominantly work on the AHP programme and also spend some of my time on the Educator Workforce Programme leading Priority 5, which is the Principles work stream. The SRO for the work stream is Beverly Harden, who I'm sure the majority of people know on this call. She's basically everybody's boss in AHP, who works in WTE and NHS England and has education and training and the workforce within a remit, including the educator workforce. If we go to the next slide, I'll just give an overview of the rationale and the remit of the programme, and also what I was asked by Beverly to make sure and ensure when we're developing the work stream and creating a plan for what is going to be the maturity framework. The programme can't exist without the stakeholders that we work with. We're literally too small. We don't have enough time to deliver what has been set out as a Herculean task to really look after the educator workforce. So we really do lend on experts that work within the field and those that are working at the coalface. And we're very thankful for those that have worked with us to date. We can't create anything new. We are to use existing standards, principles and frameworks that are out there. I should also mention we're looking at this from a multi-professional perspective. So there are more professions than others that are a bit more advanced within this field, including AHP that has a framework. And when we were developing the maturity framework itself, the end game is to make sure we have a product that is going to support employers and providers to consider the maturity that they have and to consider a mature approach to educators in their workforce and ensure that that's part of wider workforce planning and also service planning in general. And obviously we have to be mindful of those new ambitions, the 3 key shifts, and also the other policies that are in place within NHS England that we have to make sure that we are aligning to, not overlapping, but also utilising what they're already capturing in terms of data and evidence, so we're not being onerous and asking new things or duplication. So that would be the People Promise and the Quality Framework and SLEC and EDI. So if we move on to the next slide, I'll just explain the phases of the work stream itself. I'll go into a bit of detail around the guiding principles that were developed within the programme. So we have some subject matter experts working on the team that helped develop that. And we also worked with programme leads in NHS England that have a responsibility for each individual profession to make sure we're getting that multi-professional aspect. The development of the maturity framework was what I led on, and we'll go into detail of the working group that we convened. That was multi-professional, people working across the NHS in all areas to make sure that we are capturing everything. And then I'll talk about the testing phase, which is where we're at, and the implementation and the ask that we will have today for some people who might be interested in helping us. So if we move on to the next slide, I'll just explain that we really had to go to the basics here when we were developing the work stream. So, you know, the strategy itself talks about principles and standards. We had to be really clear what a principle is and a standard. You can read it for yourself. But we also had to really hone down on what we can do as NHS England, where we feel principles are definitely within our scope, our sphere of influence, but standards are set by other organisations. In the instance of AHPs, obviously HCPC, professional bodies would have a say, but also multi-professionally, you've got professional organisations, royal colleges that all exist for different reasons, and they all have a different take on the educator and the educator workforce. That's not to say we haven't been talking with them at great length. There are roundtables where we have gone and made sure that they know what we're doing and they're comfortable with what we're doing. But the work stream itself has been focusing on the principal development. So if we go to the next slide, I'll talk briefly on the 10 guiding principles. So Beverly Harden and Ellie Melcombe, who was the AHP fellow working on the London team, went away and did some analysis on existing frameworks and what may be gaps that could be considered in terms of guiding principles. So we went away and we developed 10 guiding principles that were ironically a starter for 10 to begin discussions, to start that consultation with people to see has everything been captured. So I won't go to great length in all of them. If we go through them, you'll see that it's around infrastructure, it's around making sure we're building population health and safe, effective services through education and training. We've always seen that we want to be considering protected capacity, and we want to make sure that workforce planning of the educator is really integrated into workforce strategy. EDI really did come up as well. We need to really also ensure that educators are professionalized and invested in, and also that we're building multi-professional teams that are collaborative and respectful, making sure that we're covering the capacity and capability through partnership working, and making sure that education and training is a key driver for transformation, and to ensure within all of this that there is continuous improvement throughout. I should mention the programme does work in a very iterative way. We're very agile. We need to keep improving as we go along with the information that we're getting. So if we go on to the next slide, you'll see what the phase 2 principles have resulted in through the consultation that we did with the working group. We met twice, and we went away and did a large piece of analysis around the feedback that we got from those 10 principles. To go from one slide to the other is a disservice to the work that's been done, but we're only here for a short time. But you can see that we captured the majority in 6 principles. We were told 10 might be too many. We took that as feedback. We also saw that there was repetition, maybe a bit of duplication as well. And we took that away and we did the analysis, and Debs will speak on the maturity statements that were developed. We came up with themes that could be attached to them. So you'll see that these top level principles are a bit more succinct, but they're the 6 principles that we're working by that we would think that every organization should have if they want to achieve maturity. So just to give a little bit of a overview of how we expect the principles to be used. If we go to the next slide, you'll see that there were 6 core principles. Within each principle, there will be indicators to support an understanding of how you would achieve the principle. So you'll see that there's about 3 or 8 for each one. And then indicative evidence will be something that we'll have within an appendix that shows activities, metrics that can be utilized to show that you're achieving that level of maturity. So that's it in a nutshell in terms of how we develop the work stream and the principles. Debs is going to speak now on how we worked on creating a maturity model for that.
Okay, so how do we use such a huge amount of information that we've gathered? How do we use all of that stakeholder informed intelligence to demonstrate educator workforce maturity? Next slide, please. So, like much in policy and guidance, it all looks tidy and linear on the page, but in reality, we know these things are a lot messier in practice. So aspects of each principle will intertwine to provide a complete picture about an organisation's approach to their educators. And we'll have to combine evidence across principles to demonstrate maturity. So on the next slide, we have some statements which describe what we might expect to see when there's a mature approach. Firstly, we might expect that the educator workforce infrastructure is established equitably across the workforce with designated accountability. Secondly, that the educator workforce is recognised by organisations as a key facilitator of employer responsibilities for regulated activities. So that's as stated in Regulation 18 of the Health and Social Care Act, and that's integrated in organisational governance and assurance processes. So you'll see in this work, we're really trying to draw attention to not new bits of policy or new bits of legislation, but trying to find ways of facilitating what we should always have been doing as organisations, as employers. Our third is that there would be sustained financial planning and resourcing for educator workforce, which includes integration of educator workforce in business plans, that there's educator quality and development and well-being being prioritised and maintained, that equality, diversity and inclusion are embedded across education and the educator workforce, including recognising educators as culturally competent role models, driving the narrowing of health inequalities. And then that quality improvement approaches are adopted to support sharing and spread of educator best practice, including the contribution of educators to organisational performance, safety and productivity. So I hope what you see in those statements is a sense of bringing the educator workforce really into business as usual for the whole of our healthcare delivery. Next slide, please. So how can this maturity be evidenced? On our next slide, Antonio had previously described how we have principles, indicators and evidence. So if we take principle 1, which is about leadership roles and infrastructure, then the first indicator under that principle is that there will be this named accountable senior leadership for the whole educator workforce. And colleagues will say, well, what on earth does that look like? We provide then some indicative evidence. So in secondary care, that might be a consistent named individual who's got this as part of an executive or non-executive portfolio. In primary care, it might be a GP partner with oversight. The educator workforce might be a standing agenda item on senior strategic planning level meetings. We might expect to see operational and organisational linking of workforce planning and educator workforce capacity and capability. So, for example, in secondary care, we might expect to see links with the work of the priorities of the Chief People Officer and the Chief Finance Officer, or in primary care, how that links through to the priorities of the practice manager or the primary care hub or network. We'd expect those accountable senior leaders to be receiving and sharing reports from mandated quality forums where the educator workforce is a standing agenda item as part of how we address concerns about care and quality of care, safety and so on. And a further illustration, just to kind of give you a flavour, on the next slide, we're talking about principle 4. This is the one around governance, quality, policy and strategy. And here we're talking about, in indicator 2, the evidence of the role of educators as an enabler for that employer responsibility for safe staffing and the meeting of standards for training. So what might that look like? What sort of evidence might people be able to provide? They might be able to demonstrate that they have accountability measures and key performance indicators which are explicitly linked back to that regulation in the Health and Social Care Act. We might see that in their quality monitoring templates, in their quality reports, in their quality action plans. And we'd expect that to be informed by established intelligence such as the NHS wte Educator Quality Framework self-assessment, particularly domain 2 of that. And we'd expect things like the approved learning environment in primary care to be used as evidence, where we'd see for AHPs, the AHP workforce featuring that. In terms of CQC, key lines of inquiry, particularly S6 and E3, which are about the training of staff and the learning from a learning organisation, learning from incidents and so on. And again, we have forthcoming in the not too distant future an educator voice survey where we might see this featuring as well. So hopefully you're getting a flavour of how all of the evidence we're suggesting will be in things that we are already doing. The nursing SSSA, COP-Med and COG-PED for postgraduate medical training. How are those standards being met? So this is that thing that Antonio referred to, that we're not reinventing standards, we're providing principles to ensure that these standards are embedded in practice and providing ways of self-assessing the extent to which that's happening. Next slide, please. So what does maturity actually look like? As we begin to roll this out, we're developing clearer insights about what maturing and beginning might look like. It's evolving, but in essence, an established organisation will have good evidence for the indicator that's inclusive of educators across the workforce, across professions who are providing care in that organisation. They will have ongoing mechanisms for quality assuring those established practices. So they haven't ticked the box and then decided it will all look after itself. That's now built into their business as usual. They're going to continue to pay attention to educators and see them as key for progress with the 3 key priorities. The implementing will be that they have some evidence. There might be really strong evidence for some of the indicators, but it's not yet, say, inclusive of educators across the workforce. Maybe they're really strong in nursing or midwifery or medicine or pharmacy, but not in some of the other professional groups. And so they're building that educator workforce into their plans for the 3 key priorities. And then finally, there will be a lot of organisations, because there has been a lot of neglect, probably 75 years of the NHS and 75 years of neglect of the role of educators in that, where we need to, they're beginning to recognise that there are these gaps, and they're beginning to make plans about how to address them. So we know this is very early stages in self-assessment, and through the soft launch that's coming, we'll be working with some early adopters to see whether we can refine these even further. Next slide. So we've already said there are 6 indicators, and there are 6 principles, and between 3 and 8 indicators, there's a lot to take on. So where do we start? We suggest step 1, which is just 4 indicators, will create the foundations. Then step 2 will move that up to 10 indicators. And that stage, you've got your fundamental indicators with something from every principle. And then for many organisations, hopefully in the end, they will look for comprehensive evidence across all 6 of those principles, and that those are embedded in practice. Let's have a look at what that means. So establishing the foundations, as I say, it won't provide evidence across all of the principles, but it will demonstrate that an organisation is committed to the leadership roles and infrastructure of the educator workforce, that there's integration of that educator workforce in their considerations for business planning and resource investment, and in governance, quality, policy and strategy. So there are 4 indicators from 3 of the principles that we highlight here. They're the ones about accountable and responsible senior leadership, because we know from research that where there is accountable and responsible senior leadership, initiatives stand a better chance of getting embedded in practice and being sustained. And then we want to see mechanisms for ensuring that there are distributed funds for education are allocated where they're meant to be for education and educator activities. And then we want to see educator workforce really being embedded in governance and quality. If we've got a whole bunch of incident reports around something, how are we considering the role of educators in addressing those concerns? Next, please. Important point at the bottom of this slide, which I must say out loud, which is we're really saying to organisations, if they do nothing else, at least do this. And I do think these 3 principles and these 4 indicators would be game changing if we could see this embedded across practice and across organisations throughout the NHS, and respond and reflecting all of our professions that work in those environments. Next slide, please. Step 2 is about creating the rest of those fundamental indicators. So at this point, there will be something from all of them. I'm not going to go through all of these in detail, because what I want to move on to do is really contextualize each of these for you from my attempt to put an AHP spin on them, and coming at this as an AHP myself, speech and language therapist, and very much wanting to see how we can make this work for the allied health professions. So on the next slide, please. I want to put a call out to colleagues, I guess, that think about the implications and the considerations for the AHP workforce in relation to the principles that I'm going to talk about on the next slides, and think about how you can be evidence ready when you start to see your organisations really grasping the self-assessment matrix. Next slide. So this first one, that named accountable senior leadership, we are making a lot of, I've said it several times, it's probably the thing I've said most in this webinar, and that's because we really feel it's the kingpin here. We really want to see someone at a senior level in organisations who is having an oversight for the whole of the educator workforce, not just for one section of it, not just for medicine, not just for nursing, but thinking about that whole workforce. For AHPs, this is rarely going to be an allied health professional. It could be your director of nursing, it could be your chief people officer. It will be different in different organisations. It might be assigned to somebody, and I've seen this happening in some organisations, that it's assigned to a non-exec director. Think about how you are relationship building with this senior person. Think about how you can make sure they have an awareness of allied health and its educators. Provide illustrations and examples of AHP educator contributions for those high-level metrics that will be bothering them. How are they making a contribution to recruitment, retention, to patient safety, to quality of care? How are they making or helping you to respond to recommendations that might have come from CQC inspections, for example? Next slide. The responsible leadership, so this is where it gets a bit more granular, and it may well be that you have a very senior allied health professional who holds this position, but that won't be the case in all organisations and in all parts of the systems. So again, think about relationship building with the post holder where that's not an allied health professional, and with others in the organisational structure where, you know, how do you build with the accountable person, with your peers across other professions, and with educators and the wider workforce. Have an AHP strategy that aligns with national and professional educator strategies. Oversee the implementation of that. Ensure that those educator considerations are embedded and embodied in your business as usual, in the AHP part of your organisation. How are your educators part of AHP quality, AHP business planning, and other high impact indicators that we've talked about on previous slides? Gather and share the illustrations and examples of AHP contribution to those high-level metrics and share them with your responsible and accountable leaders. Next indicator. This is about protecting time for educator roles and activities. So we know that this is really very different gradients of maturity with this across professions, across organisations and so on. We're not suggesting that we're going to get there overnight, but as AHP leaders, consider reviewing job descriptions for educator roles and the titles too. Are you thinking about how people's job plans, or how you could be using job plans to really indicate where the educator components of those roles are and how you might protect that time for education, for supervision and so on? Can you see that educator time is visible in your local timetables and rostering? Are you able to support and protect time for educator pillar learning and development opportunities for those who have educator responsibilities? How do you promote that from early career? And how is that reflected in your colleagues' appraisal? So really making developing as an educator a career development possibility for your AHP workforce. Next slide, please. So partnerships and system-wide approaches for safe education and training for the whole workforce. AHP leaders, consider what the mechanisms you have for monitoring to ensure that there's access to sufficient profession-specific educator capability and capacity. We know how important that is to capture and support the learning needs of some of our smaller professional groups. How are you doing that? How are you demonstrating best practice and sharing that with your colleagues? So how might you use NHS educator provider co-produced, co-designed, co-owned risk assessments? How might that be part of your quality monitoring? How might you have partnership solutions? What might something like flying faculty, so an innovation like flying faculty, be of use in this space? Escalate your concerns through your educator workforce infrastructure in your organisation. And if that doesn't exist, keep talking about educator workforce infrastructure until it starts to be something that's socialised in your organisation. Promote and implement safe learning environments, and also the requirements under the quality framework. Again, domain 1 here about learning environment and culture. Next indicator, which is about these mechanisms to ensure distributed funds. So you yourself think about what audit trail you have for funding or for contracted education and training provision. Do you have an audit trail? Do you know what tariff is available? Do you know where that tariff is? We're seeing increasing, this was almost like a kind of, there was anxiety about raising this in the beginning, but we're seeing increasingly that organisations really are taking seriously where the money that comes to them for education goes and how it is spent, and whether it's spent on the things that it's meant to be spent on. Again, we won't change this overnight. So feed any intelligence you have back into your educator workforce infrastructure. Escalate concerns, highlight risks and barriers, but also promote, celebrate the successes, your educator successes, and the impact that that has for high-level drivers. So we often know in quality improvement, if we work with the driving forces, we sometimes have a better chance of overcoming those kind of restricting barriers and challenges. So really don't overlook, we can get very bogged down in our concerns about what's not working, but look for those small successes, even if they are small, and promote them and share them. Educator workforce planning as an explicit data-driven concern in business planning. So how often have we said, oh, they've created a business plan, they haven't written the AHPs into it, but not only have they not written the AHPs into the business plan, they've certainly not written the educators into it. So how do we prompt that consideration about the educator workforce? What learning and development might people need to be able to meet the ambitions of this business plan? How can we be data-driven in those considerations? So can we triangulate with existing dashboards, incident reporting data, vacancy rates, planning for necessary educators to support the strategic shifts, and so on? Can we use those business plans to demonstrate links between workforce planning and necessary educator capacity? Can we incorporate educator workforce into annual reviews in each financial cycle as part of our own financial reporting from the allied health perspective? And again, can we feed that intelligence into the infrastructure? Next slide. You'll see there's some repetition here. Hopefully that's reassuring that I'm not asking for something new or prompting something new for every indicator. This indicator is about the educator workforce as an integral aspect of governance and quality. I think this is really the game changer, because if we can demonstrate how getting education right really helps us with our quality ambitions, then I think we will start to see the educator workforce really being taken seriously. So it should be a standing agenda on our AHP quality forums, where we're making that relationship between educators, education and patient safety really explicit. We're utilising educator capability to address quality concerns. And again, we're feeding that into the educator workforce infrastructure. Next slide, please. The whole workforce educator capability is embedded in organisational quality policy and strategy. So again, this is attributing and demonstrating the value of continuing professional development, supervision and a learning culture. Have we got this into induction and professional development review and appraisal? Are we encouraging all professions and all career points to develop as educators? I've talked about it being part of quality monitoring, so I'll move on to the next slide. Is there organisational evidence of approaches to ensure sustainability of the educator capability and capacity? So are you establishing communities of practice for your educators? Do you have substantive educator posts with job plans that articulate impact? Are you looking at things like legacy mentoring as ways of retaining educators? Are you promoting local educator conferences, the learning and development of educators and supervisor, celebrating successes, as I've said, and maybe encouraging more educator development earlier on in the career by supporting access to educator pillar development? And I know you've got some good examples with the enhancing teaching standards in the NHS varsity training, which colleagues might be aware of. Next slide. Inclusive learning environments, this will be familiar to people. So things like the safe learning environment, the quality framework, the primary care approved learning environments. How are you evaluating that from an allied health perspective? How are you hearing from learners, sharing concerns, successes, thinking about impact, working in partnership with your education providers? Next slide. Back to Antonio.
Thanks very much. So we are in phase 3, where we've worked with all of the information that Debs has explained. And we are at the stage of testing the self-assessment framework. So we're soft testing at the moment. We are looking for early adopters and volunteers. I did see the Q&A, and we'll give details of that by the end of the webinar. I can't really make it more exciting than it is at the moment. It's a spreadsheet. You'll see the colors of each principle there. And what we're wanting to do is really test the rationale that we can have the evidence captured before we go to a web-based version. So you can see that the steps are there, each principle, each indicator. You have the capability of recording your own evidence against that from your organizational point of view, how you would feel in terms of your maturity, so established, implementing or planning, and then an action plan of what you think you need to do to improve. Down the line, we might be in a situation where we can provide case studies and examples, but at this stage, that's what we have at the moment. The next slide is just to explain how you could do it from a step point of view. So if you want to do the top 4, can you do that from your organizational perspective? And your feedback on that, if you're interested, would be greatly appreciated. And then the next slide, just me trying to make it look better than what it is currently, where you can actually filter by each principle. So once we go through the testing phase, we should be in a position where we'll be able to create a web-based version in HTML and reflect it to other tools that are already out there. We're modeling the CQC key lines of inquiries tool, which is utilized a lot. And within that version, you're able to go in through different levels from you can have more of a tool based on your perspective, where you work, what level, and what step you want to work from. So that's what we're aiming for. So in terms of the next steps of the work stream itself, we're going to finalize that version that I've just shown in the slides. And we're going to work with early adopters. We will create guidance and video instructions just to help you with the self-assessment. And like what we're doing today, we're socializing the concept. So we're going to be at webinars, and we'll be continuously promoting what we're doing whilst iterating based on the feedback that we're getting from the early adopters. We're thinking that through autumn 25, we'll be getting the feedback that we need to really work up new examples and perspectives from different practice settings, different professions, those case studies, things that might be able to support you to use the tool. And hopefully, after the autumn, we will have that web-based version that will be utilized by anyone who works in the NHS. And that's the ambition and that's the aim. And we're currently on track, which is good. So in terms of the calls for support, Debs.
Well, it's probably jointly,
yeah,
Antonio,
please,
to be honest. Yeah. So next slide, please. So in terms of allied health professional colleagues, please do come forward if you think you can help us with testing, or you can help us to, inform whether we've got the right sorts of indicators and evidence on our appendices. Even aspects of what we've pulled together would be really great to get some further AHP eyes on. We have had allied health colleagues involved from the beginning, so I'm confident we haven't completely overlooked the professions, but there will always be something that we get caught out on, and not because we deliberately have tried to be caught out, just because there's an enormous amount to do in this piece of work. Helping us to socialise this, so it might be in your organisation you're starting to ask questions about, has anyone heard about the educator workforce maturity framework? Is anyone leading on it? How can we get involved in the work, and so on? So be proactive. Who's already thinking about that in your organisation, and who might need to be thinking about it? Provide us with AHP insights and feedback, and please do keep in touch with us through the Educator programme. I think that's us.
It certainly is. Thank you so much to Debs and to Antonio for a really comprehensive overview there. We're getting lots of thumbs up, claps and what have you, so very well appreciated. And I'm just delighted that we've had such a great representation from our AHP community here today, joining to hear this important work. And I noted that we've had some educator leads on the call, we've had some strategic leads, educators in practice. I've been scanning through the list, so delighted, and I'm sure many of you will have really benefited from the information shared today. I'd also like you to think about, what are your takeaways today? Thinking about those 6 principles. There's a lot of detail that's been shared with you today, and an opportunity for you to go away and think about that, and how you're going to, who do you need to speak to in your organisation? Who are your key connectors? Who are those strategic leads that perhaps you need to go and have a conversation with if you haven't already, to really think about how we can embed this and make this, it's such an important part, the educator workforce, of our overall strategy to ensure that we really do focus on that high quality care and delivery for patients, because that's essentially what we're here to do by having those highly skilled, trained AHPs within the NHS workforce. So do think about that, and we are always here to answer your questions. Obviously, Deb has shared with you that email address. We'd like to thank you all very much for committing the time today. There's been many of you on the call. We'd like you to take the opportunity to give us some feedback if possible through the QR code that we have available to you here. You'll get a certificate of attendance. We really want to continue to keep working on this webinar series, so all feedback is gratefully received, and you will also get a copy of the slides alongside that when you present that feedback back to us, so we'd really appreciate that. Thank you. And then we do have another webinar coming up, not long away already. Please do register for the next one, which is empowering AHPs leading through research and innovation. We've got another great range of speakers for you, and I'm sure, please do spread the word. I'm sure many of you may have attended some of our previous webinars, but we want to continue to promote the information and priorities, and sharing that information that we have at our disposal, hearing from some great speakers, hearing some great practice examples and innovations that you can take away and think about in your own areas of work. So I'd like to thank once again our speakers today, Professor Deborah Harding and Antonio De Gregorio, for their time, efforts and expertise today, and I'd like to wish you all a very good rest of your afternoon. Thank you very much for joining us today.